Thanks, Ashley,
Yeah,
for getting us started. And thanks to our sponsors. Looking forward to another great night of IGSPT Journal Club. We have great speakers here with us tonight. I'll introduce each of you quickly, let you tell you a little bit about yourself. I think we'll probably plan on going over Joe's article first, and then Dr. Gobezie and Joseph will talk about your two abstracts and learn about the two of you. So let's start with, let's just quickly, Joseph, tell everybody who you are and where you work and what you do real quick, and then we'll get back to you after we talk about Joe's article.
Absolutely. My name is Yusuf Shoshani. I'm the clinical director at Genie Health. I'm an MD by training. I've been working with Dr. Gobezie, the co-founder of Genie Health, for over 15 years. My background is clinical research. And since the inception of PT Genie, I've taken the role of the clinical director. So I'm in charge of correlating the tech development and making sure that it talks hand in hand with the clinical needs, on top of all the research that happens at PT Genie and Genie Health in general. So that's who I am. That's what I do.
Great. Thank you very much for joining us tonight. I met Joseph this weekend at the conference in where the heck were we? I'm still lost trying to catch up on the sleep in DC. Yeah, it was in DC. Yeah. Thanks. Yeah. So yeah, they have some great products. Just some really amazing things that I think people are going to love. Reuben, tell us, Dr. Gobezie, tell us about yourself quick.
Reuben's great.
Reuben.
Thanks, Rob. I've been friends with Mike and Ashley for years, and working with them and watching what the IGSPT is doing. Yeah, as Yusuf mentioned, and I love it. I got introduced to ICUS this last spring, and
yeah, that's what I heard.
Absolutely blown away. So we're honored to be part of this IGSPT initiatives, and excited about it. And with the thought leaders in therapy, it's an exciting thing for us to be part of. So thank you. Yes, I'm an orthopedic surgeon as well. So I'm learning a lot, and I'm continuing to learn tonight with Joe and so on. So
fantastic. Thanks for joining us. All right, Joe, we're up to you, man. Can you tell us just tell us first of all just a little bit about yourself, and then I guess I'll tell everybody here our first paper we're going to discuss is one that Joe published called Telehealth Physical Therapy: More Than an Alternative to in-person care of the young athlete. So Joe, tell us a little bit about yourself, and then maybe give us just kind of a quick synopsis and overview of your telehealth paper.
Sure. Yeah, so I'm Joe Moloney, physical therapist, manager of the Young Athlete Program at HSS, Hospital for Special Surgery, up here in Manhattan. Been involved with the sports section for a very long time, former chair of our youth sports SIG, been on the Specialization Academy of Content Experts, and really thrilled to be published with IGSPT as well, and great to be here tonight. So the genesis of this article was really the pandemic. At the time that the pandemic hit, we did not have telehealth throughout the organization. And so we quickly were able to get that up and running, and I was part of the lead out team for that. And so, my caseload is all young athlete here. I'm a blend of administrative and clinical, but most of my time is clinical. So I was seeing these patients day in and day out. Some of them were patients that I had been seeing in person and then converted over to telehealth, and then others were, new that were purely virtual at that time. And that's where I really started to see all of the things that I published here that I saw were real benefits that had not, I hadn't realized, hadn't really thought about just during inpatient care. So it was very eye-opening. And then that's what prompted me to try to put this together with help from the organization, to try to describe what we were finding and what we thought that this ultimately, what a hybrid model might be able to do, and may be beneficial beyond purely in-person care.
Yeah, great. Well, thanks, Joe. And so I'm gonna start with some questions, but Joseph, Reuben, if you guys have questions for Joe, I know a lot of what you guys do is kind of related to not necessarily telehealth per se, but care that can be done, at the person's home, and getting information back to you with your product as well. So feel free to ask any questions to Joe that comes up, or if I'm asking a question and you think it relates to things that you have, feel free to let us know that too. So it should be very interactive. I don't want to control the whole show, so feel free to jump in. But I guess I'll start. Yeah, Yeah, you get ready to get hammered, Joe. We don't hammer anyone on this show.
Okay.
It's all good fun. Yeah. So my first question, I guess, Joe, was for you is, did many people at the hospital use telehealth prior to COVID coming along, and did you use it personally at all, or is it just simply once COVID hit, then it kind of blew up and started?
Yeah, I would say 99% COVID. We had a program, so we had, fortunately, the infrastructure in place on a very small level. We were just starting to roll it out and use it for just a specific program. I believe maybe Total Joint at that time. So none of us, on a daily, clinical basis, were using it.
Mm-hmm.
And then within a matter of several weeks, we brought the entire department up.
Yeah. Well, we have, in Kansas, a lot of Kansas is kind of rural. So telehealth has been around for a long time. And I think certain areas of people used it, preventive health, things like that. Doctors are seeing patients out, in Western Kansas, where the population is a little bit lower, but it wasn't really very big at all. The same as like you. It wasn't really, at least in general physical therapy, I don't think it was very big until COVID. Yeah.
Yep.
So your paper really describes telehealth for the athletic population more so than probably the general population. Explain why you feel it's more beneficial, maybe not more beneficial, but as beneficial for them as it is others.
Sure. So, I think well, tell me this. I'll talk about it in the hybrid model. Do you want more of a description at the moment of just in general telehealth? Or do you want
I think just in general, maybe to start
Sure.
with, but you can weave that into the hybrid model if you want.
So, I think that, the big findings were, I'll just sort of back up, I really saw here was home program, right? That was really, the big eye-opening piece of this is how are people really performing it when they're at home? And, as I outlined here, seeing what people are really doing versus what they're showing you in the clinic was very different. And even in the clinic, we know, right? You have to ask people open-ended questions. You have to create an environment for this young population in particular, who doesn't want to go up against authority. There's so many layers of things about their ability to be honest, right? Factor into it as well. So I think the ability to everything from, that we already know, convenience, right? Scheduling, hey, I can't get there. Well, if we do it for telehealth, we can convert visits from in-person to telehealth.
Mm-hmm.
So that we don't have to cancel visits. Those are factors. Having the family there and participating, family members who normally couldn't make it to appointments, right? So you can interface with them and have them be able to help the patient in these, situations, be able to go through the program. I even had I had a patient today, I had a patient the other day with this, that, the mom coming into the clinic, I have a patient doing an exercise. She had seen another therapist for initial eval follow-up. I saw her for the third visit. And the first thing I said was, let's go through your routine. Show me how you're doing your exercises. And she wasn't doing such a bad job, just, straight leg raises very early on. And mom said she's not doing them that way at home. When she does it, she's just lifting her leg up and down. So we have an 8-year-old child who in front of me wants to show me and be on her best behavior. We have the mom who was fortunately comfortable in calling her out on it, right? But that may not always be the case. So, the patient's showing me good exercise technique, but, maybe not really doing that at home. So when you're looking at it through the telehealth, you really get to see what's happening. And I think the other layer of this end of the hybrid model is, if you're seeing people in person and then seeing what they're doing at home, now you've got that carryover, and you can really make sure things are being done well. And, one of the examples I gave in the article was a patient who I was seeing in person before pandemic, who I had doing single leg balance, and she was on an unstable surface, so a foam pad in the clinic. And when I saw her doing it on telehealth, she was standing on an old thin pillow that was completely compressed to the floor. So when I, saw her in a telehealth visit, she was standing there, in the clinic, she was really challenged. But in the telehealth visit, she's just standing there looking at me and nothing's happening. And I realized, so if I asked her in the clinic, hey, what are you doing? Oh, I'm standing on the pillow, etc., you would have no idea that it wasn't working.
So in real life, in real life at home, what was going on? Yeah.
Okay, let's grab another pillow, grab a sofa cushion. Now we were able to do it. So, what I'm saying in the article is, if that's the way it's happening at home, and they're really not getting the benefit, now we've got a protracted recovery period, right? So with this hybrid model, can we compress it? Can we decrease the time out from everything from life to sports, the psychological, aspects of that as well, of disengagement with peers and, all the other things that come with that for any population, but certainly this population being more sensitive to it.
Yeah, Joseph and Reuben, you guys are biting your tongue. Yeah, I can tell you're biting your tongue because this like fits in perfect with your guys' stuff.
I love what Joe is sharing.
Yeah,
it's interesting how COVID, at least for us, was that in tipping point where it drove a lot of adoption for digital technology, and the premise that Joe's I think is working off of is that, hey, if you can get into their home environment based on your article, which I read, if you can catch people doing the exercises you assign them in their home environment, so you can make the adjustments relative to their home environment, then ensure that they're technically doing the exercises you're asking them to do correctly, the better they'll do, the more compressed that outcome. And I'd love to hear, Joe, what your thoughts are, coming from that perspective on remote monitoring, because that's just dialing up another level, right? I mean, if Absolutely. You have and there's all kinds of different levels of remote monitoring, but I'd like to hear, what is your take on that as pertains to what you said?
Sure. I think it's fantastic, because, again, just my own, how I approach things, every visit that a patient comes in, how are you doing? How's the home program going? Create an open environment for them to be honest. I'll lead them a little bit saying, hey, I would imagine you're probably not doing it every day. So, because if you say, are you doing your home program?
Yes, of course I am.
You're not going to get an honest answer out of a kid. So yes, we do have our electronic platform has the ability for remote monitoring in just in one sense, that they can hop on the software and log in every time they do their exercises. So,
it's really just a check. So it's really just kind of a check. Yeah, I did it. Not this. It's not. Yeah. So a low level monitoring.
Yep. So yeah, I think that's a fantastic adjunct to this. And again, I said, as you said, can we really compress? I think we can probably really, I don't want to say speed up, but shorten the length of recovery. Think about it, because I had a patient say this the other day. He said, when I was in this past few months, I've been in school. He said, if I wasn't in school, I'd be a lot better by now, because school detracted so much, right? And we were talking about, he was saying, if I was a pro athlete, I was getting care every day and I'd be a lot better. And I think that's exactly what we're talking about here, right? We know if people can get more care or provide their own, we're probably going to shorten that, there's human, limit to it, but we're probably going to shorten that length of recovery. So I agree completely. Remote monitoring would really help tighten it up.
Yeah.
Do we know? Do you guys know? Are there studies out there that tell us? I think I've seen some in the past, but I'm not 100% sure that tell us what percentage of someone's home program they actually do, or they do correctly. Do you know? Is there literature out there?
Oh yeah.
Yeah. Well, so what does it say? What does it say? I mean, I know it's not 100%.
Well, there are quite a few studies out there. I mean, they depending on what from what I've seen, the compliance rates with home exercise programs. For example, there's a pretty big study of Australia that's showing low back pain, compliance rates less than 20%.
It's horrible.
It's horrible. It's pretty bad. And like to Joe's point, of course they do it all the time, every day, twice a day, but in reality, we know clinically it's not true, right? I mean, so, what do you think the implications are, guys, for cost? There's so much pressure. I mean, look what's happened to PT reimbursement rates over the last 5 years. I mean, there's so much pressure everybody knows you need PT. Everybody knows it's a good thing. It's genuinely a good thing. Everybody knows that most patients love their therapist. They love them more than the doctors most of the time, for sure. What's the implications of this? Like Joe said it well, I think the honesty, okay, which has implications on the value of therapy, meaning if you extend it longer because you're not doing it, it's more expensive, right? And the outcomes are less. So what do you guys see a play there in terms of the current pressure now we're seeing economically?
It's me personally, I think you'd have to look at the cost to benefit ratio. And I don't know. I mean, I'm not a business owner. I don't own my own clinic. I'm not the manager of a clinic that knows all the numbers and everything. So I don't know what that is, but I think there has to be some kind of threshold. But I don't know what it is. I don't know. Maybe Joe, maybe you have a better grasp of that.
In terms of the cost of telehealth visit versus an in-person, or
No, in terms of the non-compliance.
I'm sorry.
Slowing down
Yes.
recovery rates, you know what I mean, and costing more money. Effectively, it's costing somebody, whether it's the employer, whether it's the health insurance company, whatever.
Or you paying your insurance,
yeah, you pay your insurance,
Yeah, I mean, to your point about the how many people are doing it, yes, it's very low. And again, we were, I'm not patting them on the back. I'm just saying that is such a big focus for us in this world of youth sports. Keep the program short. Ask them every time they come in, as you talked about, remote monitoring, keeping a checklist, bring it in, asking the parent when they come in. So it's the question of, are you doing it? And then, hey, mom, dad, are you seeing it? Right. But I do think that, yeah, there's a strong correlation between are you doing things consistently versus inconsistently, and how long it takes for you to recover. And again, I just proposed in the article, the manuscript there, that maybe if we're doing some telehealth and we compress the duration, we might save some cost as well.
If no one knew any better, we could be talking about Weight Watchers right now. The behavior pattern is not, I mean, there's a lot of stuff
right.
this applies to, right? I mean,
yeah.
I have a question, Joe. I appreciate the article, and actually listening to you and reading the article. You echo a lot of the stuff that we at Genie Health actually are promoting as well, with the hybrid care and like the feasibility of like just extending the care outside of the office. I guess my question to you, with what you said at the beginning, in your organization, telehealth wasn't something of a normal thing, like, right? I get the patient perspective of like, oh, I need this is going to save me time, all that stuff. How was the adoption of that telehealth, of a new technology, to your staff, to your coworkers, knowing what we know now in the PT world? Like, it's a little bit hesitant to adopt change. So how was early on the experience with your staff?
Yeah, I definitely think that there was a learning curve there. And I think, a concern of, well, how am I going to, replicate this right at home compared to I mean, I think you bring up a great question. Like, when I compare to doing in the clinic, I've got my equipment, I'm physically with people, I'm seeing them 3D, all those other things. And now I'm just looking at a camera and they're in their bedroom, their mom's sitting on the bed, and right. And they've got an ACL injury. I mean, I know that's what we always talk about, ACL, right? But,
right.
They've got something, higher level. What the heck am I going to do here? Right. And I agree with you. I think it is high stress. And I will say, just to answer your question, by the other end, once you get into it, you're like, this is great. Right. I'm not saying it replaces being in person.
Yeah.
But,
yeah. Big point.
It's absolutely, I'm doing them. I'm doing telehealth still, every week, many days. Again, some people are purely telehealth. We have some early post-op that, they're out of state, and just like, Rob was saying at the beginning there, they don't have access to our clinic. I'm also licensed in Pennsylvania. So people are coming in from Pennsylvania and doing surgery, and then they're, 150 miles away. I'll be doing telehealth with them, and some blended. But yes, it's very, very, you can be very effective. And again, a lot of these benefits, you see what they have access to, right? I have a gymnast right now with an elbow surgery who has access to a bar, at home that she can hang on, and we can start doing, distraction loading with her, those kinds of things. Awesome. If I see, it's one thing to ask that in the clinic versus being able to see that.
Actually see it at home, yeah.
And build the whole, not only I think you see what they have access to, where they can do it, And then you're able to teach them how to do it. You're able to show that parent who I said earlier may not always be there, how to give them the feedback. They can change position, go side to the camera, front to the camera, all those different things. And, you really can, treat them effectively, and you can really optimize what they're doing day in and day out.
Joe, how long are your telehealth sessions? Like, what would you say your average telehealth session would be like?
We're slotted for 30 minutes. And I would say, by and large, that's what they are. We have 45 for our evals, then a 30-minute for our follow-ups. And there are some that end up shorter than that. People who are really, up and running, they're early post-op, their program's pretty simple, they're fully engaged. Maybe, a lot of times even the older, if you're, late teens, early 20s, that you don't need a full half hour. They've got them, there's not a ton that they can do because they're so early post-op, and that's an advantage too, right? And that was one of the things I brought up in the article. If you've got somebody who may not be willing to travel for such a short visit, they're far away, et cetera, but they may be very willing to do that, for, via telehealth, you can get that, continuum of care.
So Joe, how often do you see, like if you have a standard patient, I have several questions that kind of stack onto each other. How often do you normally see them with telehealth? What determines, other than, like you said, location, if they live far away or they can't get in or some reason, or there are other reasons why you would choose telehealth over in-site visit? And like with your hybrid visits, is it once a week in the clinic, once a week on telehealth? Is it twice a week in the clinic, once every couple of weeks in telehealth? How do you model your program and decide on those type of factors?
Yeah, I mean, I hate to give you the answer that's very individualized.
Yeah, but it probably is, right?
But it really is. Yeah. I mean, I tell you, it's everything from, those who are coming in that maybe you've done a telehealth, but that they're spot on. You know who your patients are who are coming in, they know what they're doing, that they're reliable, et cetera, that you can really focus on your in-person. And you've got the other people on the other end of that spectrum, that patient I just mentioned a moment ago with the mom who's saying she's not doing them that way. Now we're ramping up what we're going to be doing with her for telehealth, because it's like, she's supposed to be working out twice a day, every day at home. We really have to make sure that that's working well. Other models, we have kids right now, right? The summertime in Manhattan, people are going to camp, et cetera. So we've got people who are now purely telehealth over the summer because they're at, their summer home, still in New York State, right? We got to do it where we're licensed, et cetera. Somebody who has access to a gym, that's another thing I do. I see people, at their local gyms or their gym in the building. That's another great one for this, right? You want to see, what access to equipment, because again, you ask people, what do you have access to? Take a video or pictures and come in. Well, if they're there with their phone and they're walking through the gym, you could prop it up, you put them on the leg press, you set them all up, seat position, the whole thing. So, all of those sort of factor into that frequency. But I would say it's everything from rarely because they're doing great to frequently because they really need a lot of that.
Yeah, that's good. Reuben, Yosef, you got any more questions? I got a couple more, but are you guys cool? You got?
I have a question. I think, Joe, again, my question are focused on the clinician, on the provider, because
sure.
at the other end, the patient is just, waiting for the instructions. If that is, I guess my question is, during this experience, at least the young athletes, what are some of the features that the clinicians or like the team members would like to have access to during a call, other than just like seeing the patient? Are there like a list of like to do on your end of like the spectrum of things that you would rather have on the call, during the call, that would help you with your interaction with the patient? Is that
Fantastic question? That's a great question, Yosef.
Yeah. So on two levels. So one, you mean from a sort of, if I had to pick technology, what would I love to have?
That kind of deal. Yeah.
Would that be one? Yeah. Certainly, look, goniometric measurement, right? We're holding a goniometer to a screen, trying to get the patient or the parent to line things. I mean, that's not unique to the young athlete. But again, if we had a device, if I just really go far out there, if we had a device that could do that, or I tell you one thing, I had a patient the other day, put an inclinometer on your phone, put it on your shin, try to do the best you can to get your leg vertical. They're going, they're out of town. So, how can they measure? But yeah, if you had something, technology like that can provide that
So
kind.
I asked the question because it was just like a way to say, you have to come and check us out at Genie Health.
Yeah.
The stuff that you're saying is like,
Totally knew where that was
good.
going.
Yeah. No,
Like,
we
it's
all
good,
did.
but
Well, not all, several of us did. Yeah.
there's
Well,
a lot of evolution that's happening around the technology that you're
Sure.
describing.
And I'll boast to you because I'll plead ignorance. I don't know anything about your company, so that I was not at all. That my answer was completely genuine and unrelated. So that worked out well.
It's something like that that triggers us as well, like to start thinking outside the box as well. So it's
Sure. I think the technology, I mean, look, I know there's go wait, like force plates or something on the phone that shows position. I mean, you layer in all that technology could absolutely be, fantastic and a huge help. Because again, we're in a 2D world, and that makes it, more challenging.
Rob,
Good.
if I ask one last question.
No, sure. Yeah.
quickly.
Go ahead.
When you say young athletes, what is the age that you predominantly looked at?
Yeah, just the field of pediatrics, 21 and under.
Gotcha.
Yeah.
All right.
Yo, can you give me any more? Can you give us any more? I really loved in your article, and you described the one here too that was in the article about the patient that was standing on the pillow that was flat.
Okay.
So it really it didn't work very good. Do you have any other examples? I think those are great examples. If you have any more, like where you're able to either maybe you see, or just think of things that you've seen while you're using telehealth for sports stuff. What other things have you seen where you were able to see something that you wouldn't see and you were able to increase it to make it better, like that? Or maybe from the opposite end, maybe there are things you saw that they're doing at home that you're thinking, oh my God, no, wait, I don't want you to do that much. Let's back it up a little bit. Do you have any examples like that?
Yeah, the first one that comes to mind is step height. So if you want a person to do a step up or a step down, and you're in the clinic, you say, okay, well, look at this step up on it. How does this compare to your steps at home? Is it higher? Is it shorter? Well, I don't know, right? But you get them in telehealth and you see, right, they're doing a forward step down on a step at home that's way too high, and they're contra dropping and they're buckling, and their form is terrible. And it's just what you said there. Nope, hit the brakes. That stair's too high. Let's figure something else out. Can we put something below it that's safe, that you can step down, and we shorten that height? Conversely, can we, increase it? What do you have at home, to do step up, step downs if your steps are off? So, that's one. I think another just general advantage that we talked about a moment ago was be able to see them in their sports environment, right? So
yeah.
be able to see these kids out on the field, running around in their backyard, particularly, you think about the constraints that a lot of people have in their clinics. I think, a lot of us have people running around the parking lot, right? We've got a small clinic, you take them outside when the weather is good. But here you can, have them out at a field in their backyard, et cetera. So there you can make a lot of adjustments. You can develop, agility drills, et cetera, based on what they have. Floor surfaces are another one. Are they slippery or not? Can they safely do things?
Or is it even safe for them to do it at home? Yeah. What you're asking them to do. Yeah.
And then household items, right? What do you have? You can see if they say, I don't know if it made it into the article. I had a patient who was doing ankle exercises, and she said she was putting a weight on her foot. She was an ankle patient. I don't think that made it in there.
I don't think it did. I don't remember that.
No.
So she was trying to describe to me, I put this weight on my foot and I lift it up and down. And here what it turned out was she was taking an actual plate, putting her foot through the hole. She had like a 10-pound plate. She was apparently sliding it over her foot. And that's how she was doing ankle dorsiflexion.
Oh my gosh.
Wow.
So,
Crazy
What's
stuff.
another injury?
Yeah.
What's another injury?
Right. Absolutely.
I'll add
Right.
just briefly, unrelated to that specific question, that I think we also underestimate sometimes the value of just our presence as the expert that the patients are looking at, and also they're just kind of like psychosocial, like emotional connection to, you get to know your therapist, and they value our thoughts and our opinions, and that reassurance of like, you're doing great. So even just like some of the intangible, non-objective things that I think, especially we experienced highly during COVID, when people really weren't getting to have as much interaction. But even now, like that, a lot of people are pretty much predominantly back in the clinic and on a hybrid model, that they just appreciate your time and your feedback and the ability to ask you questions. So sometimes just even the conversation in a telehealth visit is the most valuable piece of it.
It's probably true. That's really right. And a lot of times you don't, that could be there. That could be so strong there and you not even really realize it. Or, the patient may not, I'm sure we've all had patients where you thought, that the patient didn't, I kind of felt like the patient didn't even like me. They just acted like they were just kind of there or whatever. And they didn't really seem like you got along with them okay, but you didn't think they thought you were that great. But then you find out, 6 months later, they referred 2 people to you, and those people say, well, they thought you were wonderful. They were you were like the greatest therapist they ever said they ever saw. And you thought, well, that's not the same person. It's not the same patient that I saw. They couldn't have said that about me. And they say, no, they were. So it's whether you think it's there or not, it's probably there. Great point, Ash. Mm-hmm. Well, guys, I think this is probably good. We're just about like 37 minutes into the program here. I think this is probably a good time to segue to Reuben and Joseph. You got thanks, Joe. Joe, you're welcome. Are you going to hang on with us and
absolutely. Yep.
Throw some questions their way now?
Sure.
You can return the favor. You can return the favor now, buddy. All right. So Joseph and Reuben, tell us before we even get into your article. I think this would be a good time if you want to talk about your product just a little bit and how it relates to the stuff that Joe was talking about.
Yeah. I mean, we're sort of doing what Joe's describing, but we started looking at Larry Higgins, my co-founder, and I. He's another orthopedic surgeon. Obviously, we've been very interested in clinical outcomes for a long time. And so the genesis of the journey, Joe's described the journey where it started at the COVID crisis and people access was the issue. And that was our crisis came earlier where we report on clinical outcomes from procedures that we do to people. And we report them at 1 and 2 year follow-ups because that's what peer-reviewed journals want.
Yeah.
But the reality was we spent about an hour in the OR with a patient. We don't get the bond. They definitely like our therapists more than they like the surgeons. There's no question about that. You guys actually develop a real relationship. Ours are so it's like spot wells. But the point is we spent an hour in the operating room, and by the way, they're asleep, so there's no relationship built there either. And then we follow them up a year and 2 years later without any real insight into what happens to them in the intervening period, which de facto meant that we did not acknowledge several real things, such as what protocol for the particular procedure were they on for physical therapy? What rehab protocol did they have? What was their compliance rate? Did they actually do what you asked them to do? Did they do it correctly? All the stuff that Joe mentioned as important data points, we had no idea. We'd guess at best, what I mean? And we wanted to get to how do we solve that? And how do we get a more granular level, taking it to the extreme, we all have car insurance. And, we all know that if you get tickets, your car insurance goes up. And if you put one of those little things in your engine over your car that tracks how many miles per hour you go, and you stay in a certain miles an hour, you get a lower rate, right? So in other words, if you're monitored and they know you're a good boy and good girl, you get better deals, right? I mean, so how do we get that kind of a gig with the patients where hey, I do my part as a surgeon, my therapist does their part as a provider, but the patient's got to do their part too, which means understanding what you're asking them to do, correcting them when they're not doing it correctly, and then overall gathering their overall compliance that they're actually doing it. So, so we started with wearable devices in 2018, and then we saw, and that came because CMS introduced, Verma was running CMS at the time, introduced that by 2025, CMS, which we all know means all insurance companies, eventually is going to become a digital health transformation. And so the story was, I looked at Larry, I said, look, we had this research project back in 2016, 2018, we're going to make it a commercial product because Medicare is going to throw codes out. At that time, as you know, there were RPM codes, which meant that therapists couldn't bill it, but but unless there's incident 2, you know what I mean? So anywho, our TM codes have come out. And since that time, we went from wearable devices to computer vision devices. Just what Joe was talking about, where the front facing camera can track your range of motion in a digital goniometer. The first abstract we have is taking our technology using Google ML Kit, basically working off the open source code and showing that there's a 3-degree sensitivity, accuracy within 3 degrees of a handheld goniometer. So if you use a camera on the front facing, the computer vision AI will track this range of motion within 3 degrees. And so that's what we have the first abstract on. And that allowed us to say, hey, patient, we're going to give you a 14-week protocol, a 12-week protocol, a 16-week protocol, and that says, here's what you're going to do every day, twice a day, 3 times a day, whatever. We could customize it. And they'd have to log into their smartphone, get into the app, do their exercises by placing their phone on a little stand or on a table, and then they'd get in front of it and do the assigned exercises. And we subsequently developed patents where it's for strengthening, so you can do band exercises. In other words, a way to deploy and monetize the home exercise programs, HEP. So that's basically what we're about. Is it's interesting, Joe, you use the term hybrid model multiple times, and in our head, hybrid model means PT telehealth dosed appropriately. We only do 10-minute visits because the PT has the ability to look over what the patient's done for the whole week prior to getting on the call with them. And they already know, hey, look, you're doing well. I'm going to advance you to the next week's protocol, or I'm going to change something, or you're not doing well, whatever. So it's quick little visits. And then remote monitoring, which is the day-to-day exercises. That's the second arm of the hybrid model, followed by the third and most important, or just as a key part, which is the in-office therapy. You got to have manual therapy. You can't all do it through virtual, in my opinion. I think that's just a fact. I mean, you can't delete the manual therapy experience and the value it brings. So, to me, that's just something you just got to acknowledge de facto up front, and then work around the customized, like you talked about, Rob, about Kansas and rural Kansas. Okay, well, it may be that the guy doesn't have a therapy office within 60 minutes drive of him. So, okay, it's not ideal, but you're going to deploy something that you can measure, you can manage. That old adage, if you can't measure it, you can't manage it. You're going to manage it. So but by and large, the hybrid model ought to be some dosing. And I say dosing, like I tell my patients, like a drug. Some people are going to need more dosing in office. Some people are going to need less, some need more telehealth, more less, but you got to dose it appropriately and have the tools as a provider to be able to give a dose, just like anything else we do. And that's kind of what we're about. And so that's kind of a summary of what I'd say.
Great summary. Great summary.
Yeah, Rob, just to add a little bit, just a tad, just because Joe, throughout your presentation, you were exactly just echoing what Reuben just said. You were using the same words that we use day in and day out. So, even a couple of years before, we published this abstract that, using PT Genie to augment in office as well. So that is why I asked you, the question is like the perception from the clinician is that, oh, I'm using this as a tool. Like, would it replace me at the end of the day? Absolutely not. Like this is to augment and to extend the care and to create that connection that Ashley mentioned outside of like the office. So it is absolutely a tool that would enable you to actually do more, that would enable you to see more patients maybe. And the dosing that Dr. Gobezie mentioned, that's where the the workflows come in play to extend that care and to open much more doors, whether it's like scheduling or like revenue. There's a lot that's happening. I keep emphasizing that at the end of the day, a clinician is treating the patient. It's not the machine. It's not the algorithm.
Exactly.
All of that stuff is just a tool in the hands of the clinician to actually make it much more easier, much more quicker to reach the objective or the goal when treating the patient.
More efficient, more effective. Yeah, whatever it may be.
Yep.
Good. Well, so do you want to talk about, can we talk about your two abstracts just quickly in our last, we've got like about 15 minutes left. Well, we usually leave a couple minutes at the end in case we have questions. Oh, and I didn't say we have, participants viewing this. If any participant has any questions, please put them in the Q&A or the chat. We'll watch for those. If you have questions for either Joe or Joseph or Reuben, please ask some questions. Let's talk just quickly about your first abstract, Joseph. The forward flexion can reliably be measured with the front-facing camera used for at-home therapy that Dr. Gobezie was talking about. So tell us just briefly, I think he kind of gave the quick overview, but tell us again just briefly what you found with your study.
Yeah, absolutely. To start, everybody loves the technology, whether it's the patient or the clinician. But at the end of the day, you get all the question is like, how reliable is this? Is this accurate? Does this do any good? Like all these questions. So we said, you know what, given our background in clinical research and the data that we're gathering, we said, we trust our system, but we need to put like the proof is in the pudding, right? So we enrolled the patients. We asked the patient to just do the shoulder motion in the forward flexion plane. It was me doing the assessment. So I was asking the patient to do the motion. I would record it using the Halo laser goniometer, which has been also published in IJCSPT, I think at 2018, that it's a reliable tool. And then we did the same thing with our app. So the patient where, everything was standardized. They stand in front of the phone is put in the same height, in the same location in the exam room, and they do their forward flexion. And then we looked at the two results. And ultimately, we were like within 3 degrees, a little bit higher than what the digital goniometer gave us. So again, it was a quick way for us to say, all right, well, for the patient to be using this remotely, we are within 3 degrees of like that particular snapshot in time with that algorithm. Our algorithms are constantly changing. So we are in the process of expanding this to a multi-center study, involving 5 different shoulder planes, not just on one plane, and ultimately do multiple joints and different joints as well. But the idea was like, this is the gold standard of like using a goniometer. This is the technology of like computer vision, and we are like within 3 degrees of accuracy. So that's
Joseph, when you did those, was that when they did that motion, let's say they did one single motion of flexion, were you filming with the camera and the other device? Were they both recording the same repetition, or did they do like 3 repetitions with your camera device and then also 3 repetitions with the other device? Does that make sense? Your repetitions, were they exactly the same repetition?
They were not exactly the same repetition. So
okay.
they would do a 3 with me doing the physical motion, and then another 3 using the device.
Yeah. So you wouldn't expect it to be, I guess the reason I was asking that, because it was really, it would have been like 6 different totally repetitions, or 2 different even sets of the motion. So you wouldn't expect it to be, even if those 2 devices were exactly synced together, because they were different repetitions, really totally different times, you wouldn't expect it probably to be perfectly the same anyway. So 3 degrees is really pretty damn good, to be honest.
Absolutely.
Yeah. And these were all of these patients. I don't think it said that the beauty of an abstract, as you know, is that it's kind of brief and concise. The downfall of an abstract is there's not enough, there's like more information that you'd want. And so like, I was wondering, these were normal, healthy patients, or were these, were these actual patients, or were they normal people?
Actually, a lot of them were patients of Dr. Gobezie, but at the same time, we just walked in the clinic and said, we're doing this study, whether it's the patient or whether it's like the accompanying, family member, whoever whoever agreed, we measured it, whether they had a pathology or not. They were asked, and they gave the consent to be measured. So some of them were patients, but maybe they used the contralateral shoulder because of like other ongoing issues. So we just wanted to measure the motion regardless of like the underlying pathology.
Gotcha. Great. And was the Halo device that you used to compare your device to, has it been evaluated for reliability on its own? Does it have good tester reliability?
Yes, it was actually, there was a paper published in IJSPT.
In our journal.
Oh, yes. Good.
So it was a reliable device, and we've actually, before the inception of PT Genie, that is what we used to conduct our like clinical research. So I am personally very familiar with it. I've been using it for years, but on top of that, we just wanted something that has been verified and it happened to be like that device. So
Nice, nice. Hey, look who joined us here. Look at this guy.
Fresh off the street, man. Just rolling
Wow.
hot.
Wow. You are coming in hot.
Sorry, I'm late. I'm very late. I missed all this great discussion, man.
Hey, better late than never. You still got 10 minutes. You're catching 10 minutes, man. You're catching us at the tail end.
No, I don't want to break it up. You guys keep going. I'm just
No, you're
listening
fine.
to
You're
here.
fine. You're fine, man. Do you got any questions for him before I go to the next study?
We got a couple in the Q&A.
Oh, here, let's check them out. Let's check them out. Let's see, from Dr. James, I hope I don't butcher this, Giebfried. Does your equipment monitor multiple joints during performance testing?
Yes.
Joseph and Reuben.
Yeah. Yes, it does. It can monitor multiple joints at the same time. And in fact, what's in the abstract is a pure 2D computer vision. But we've moved to is a 2D to 3D computer vision. So it actually not only we showed you in this particular study, it was a two-dimensional plane, a forward flexion motion. But now, because again, going back to our history, 2018 wearable sensors, magnetometers, accelerometers, blah blah blah, then to 2D computer vision, which was what we did in the study. Now to 2D to 3D and even LiDAR, we have both of those. So it can do it has to do. So for example, a squat, there's many joints, ankles, knees, hips, and so on, all at the same time we can do. So yes, the answer is
that's what I saw this weekend, Reuben, was the 3D. It's like kind of blowing my mind. I really love it. I'm looking forward to seeing more of it. It's really exciting. I think people are going to like freak out when they see that, how beautiful that works.
Well, I'll tell you what, what's interesting about the whole space of tech is, we've been in it just long enough to see the transition from open source code when, Apple and Google threw the gauntlet down on computer vision, open sourcing it for everybody. And I can tell you in the future, gamification is going to a different level when you start talking about VR, AR, that's available not on a heavy processor, but on a phone. So it'll be interesting to see how that all works. But yeah, it's a lot of fun. So the answer is yes.
Cool. Another question by Lori Bogla, one of our guests from just a couple journal clubs ago. How were the patients stabilized, and in what position were the subjects tested? Thanks, Lori.
Yeah, all of the testing was done inside like the office, and it was like we didn't use any, like they were not laying supine, they were standing up, and we were just giving instruction as much as possible, because during the measurement I had to make sure that I'm using the same thing, whether I'm using it manual or during, like, to replicate what they do at home when they stand in front of
kind of every day. Yeah, gotcha.
But we were aware of that, and the other phase of the study, we're asking for, like, the patient standing against the wall or like doing it supine. So we are standardizing a lot of that to like control the scapular motion and any rocking of the torso as well. So
but
that is
it catches the torso in the computer vision, so we don't necessarily need to stabilize it per se. If you're just looking at arm range of motion relative to the thorax, if you want to include the scapular humeral motion, it's obviously a different level of analysis.
Measurement. Yeah. Okay, guys, let's go to we've got just about like 3 to 5 minutes left. The last article is At-Home Physical Therapy with a Remote Monitoring Digital Health Platform Leads to Similar Patient Reported Outcomes Compared to Traditional In-Office Physical Therapy Following Shoulder Surgery. So, Joseph, can you give us like a 30-second overview of this one, like really quick, so we can have time for a few questions?
Yeah, absolutely. So we looked at, augmenting the physical therapy protocol with PT Genie at home compared to patients who we had no clue what they've done at home. And we just compared the outcomes, because both buckets were going through the same protocols, other than the PT Genie group that we had all the control, all the communication, and we just look at all the outcomes. And then we tried to understand what is the engagement looking like when you introduce a digital platform for the different age groups, for the technology, for any challenges. And we realized that, actually older patients were engaging more with the platform, telling us that the technology is out there and there's no barriers using such technology. So that is like the premise of what we looked at.
Great. Can you tell me, I have a couple of questions for this study too. Did you, when you decided who was going to do therapy at home and who went to actual therapy, was that just a coin toss, or was it more related to stuff that Joe was talking about, like their ability to get in or not, or their distance from where you were at?
Yeah,
how did you make your decision?
Yeah, so at that time, we provided PT Genie to whoever wanted it. So as long as the patient, had the smartphone, as long as they had Wi-Fi, all that stuff. So it was more of like, here's what we do and we want you to do it. So it wasn't, only people who didn't do it is just people who didn't have Wi-Fi, or they didn't have like the approved cell phone that would, take or download the app on it. And then we looked at, we matched the cohort of the patients who just did in-office physical therapy. So that was.
Yeah, this is back in 2020, 2021. This is when the collection period occurred.
Correct.
So it's a lot more systematized now, but this was the early phases where people were asking us questions like, how do you know it's going to do equivalent? So this is really an equivalency study. It wasn't designed, this experimental design wasn't set up in a way to really test, is it better, worse? And that key question we talked about earlier, which is, what's the right dose? How much in office, how much telehealth? So this is really more of an equivalency study where we said, okay, look, we'll answer the question. People were asking, does it hurt the patient to do it? Literally, is it equivalent? And we said, okay, we'll design it to answer that question. And the patients weren't followed for a year; they were just looked at a year.
Gotcha.
And so there's a big, to me, it doesn't show that particular study's pretty weak outside of just saying, are they the same at a year? I mean,
yeah, they're relatively equivalent.
Yeah, like
the clinical outcomes were collected over a year, but like the observation during the therapy was over like the therapy period of time. But we part of our practice, we collect the clinical outcomes over 5 years, 10 years as part of like the registry of our patients. But as Dr. Gobezie mentioned, that is like the spotlight under which we looked at comparing this to that.
Yeah, you guys split them out into 6 different like age groups. Was that just simply to look at, to see how younger people had this did compared to someone who was older that had the arthroplasty?
One of the other questions we were looking at the same time was another question we got early on with the technology, because again, 2020 was, hey, older patients won't be able to use it. So we said, okay, let's segregate them out. Is that true? Is the older patients can't use it and they don't? Well, it turns out that's actually our retired.
Just the opposite.
The opposite.
Yeah.
It's the opposite. They got all kinds of time. Their compliance rates are the highest amongst all of them. It's amazing.
Yeah. So you found you found actually a higher engagement of the remote monitoring in the older patient group, right?
Exactly. Yeah.
And usually you'd think, I mean, not only just the time, but you would think maybe they wouldn't be able to figure out how to work the damn device or something like that, right? I mean, I have problems with the stuff, and I'm not even really old. So I can imagine if you get like what was the oldest age group, 81? I can't imagine an 81-year-old being able to figure that out. So you guys just did you guys like somehow strategically pick the older people that are really IT IT brilliant or something?
Surprise to us, to be honest.
This is gonna sound retarded. It's gonna sound lame, but QR codes in restaurants did a lot for us.
Yeah.
I'm serious. How you download the app is we have a QR code. The QR code, they hit it, and it's crazy what that has done. I mean, I think that in general, the technology adoption amongst people who are like back when we were kids, older and person in that age group would never know how to do anything like that. Today, no big deal. You know what I mean? I
still know some older people who like refuse to do it. They won't even do it with their, like, if you go out to eat with them, they're like old and they say, yeah, I'm not going to use a damn QR code. I refuse to do that. So you have to do it for them.
Well, I live on a farm, and my neighbor across the street it still has a flip phone, and bought an extra flip phone just in case his flip phone broke, because they said we're not going to have any more flip phones. I know
what you're talking about.
Do what, Phil?
Mike Voigt you're talking about, or
No,
Rob,
he's
He's
really
the
pretty
king of
good.
technology.
Yeah, he's actually pretty good.
Just a quick comment on that, because I am situated in our PT department, right? So I see our elderly patients coming in, and whenever they talk to our PTs here in the office, I feel like they, at the end of the day, at the end of the session, they say, all right, it's great what you said, but the genie is going to tell me everything, right? Like, so that is their perception, is like, they don't need to worry about a piece of paper. They don't need to worry about, like, all the stuff is going to trickle down to their phone. At the end of the day, they prop it, they do their exercises, and it's the connection. It's the connectivity with their provider that I think just triggers them, like, to do the engagement on the platform.
You know what's really unfair? I'm a surgeon, and it really is unfair that I've realized that PTs have a huge advantage in relationships. You know,
Oh, yeah.
my virtual PT, they like the virtual PT that takes care of them more than they like me, who they like in the flesh, which is, I don't know what that says about me or them.
Oh
or what.
no, yeah.
It's
That does sound kind of sad, doesn't it? Yeah.
It does. But you met me in real life.
Yeah.
Much.
Oh, that's funny. That's funny. Well, we got so I'm gonna ask you one more question. I've got a question on our question and answer here from Dr. Badrinath Prathi, maybe. Can this tool be reliably extended to measure any other joint range of motion? So I think it was asking about the your first study.
Yeah, we definitely in our platform, we can measure anything from the neck down to the ankle. So we're constantly, as I said, we're constantly updating our algorithms. We're constantly adding exercises to our exercise library. And we can definitely, any motion, at least in the 2D, we can get it. But as Dr. Gobezie also mentioned, multi-joint complex motions from, like, the aspect of 2D to 3D, we are able to computate it.
Yeah, great. Well, as usual, you probably saw the list of questions that I sent out to you guys prior to, so I would have enough questions. I still have way more questions for the second study, but unfortunately, we're already past our hour. So I want to thank you all for joining. Joe, Joe, I didn't mean to shut you out on this last set here. You just got to sit there quietly.
No. I
was expecting you to attack him.
I took so much of the
you to
time
get
to
in and get your hands dirty, but you just kind of sit there and observe. But that's okay. That's okay. But thank you guys all. Joe, thank you. Joseph, Reuben, nice meeting you, Reuben, digitally here. I hope I meet you sometime in the future live.
I'm sure we will.
We just put the Genie Health website in the chat for anyone interested. Also, Reuben and I did a sponsor spotlight, but I'm realizing it was like it was still PT Genie back then. We need to do some updated one. But if people are interested in more information about kind of the roots of this and some backstory, that's on our YouTube channel as well. As always, we will be sending out the follow-up. You'll get your certificates within the next 24 hours. If you don't, please reach out to me. And thank you everyone for being here tonight.
Thanks, Ash. Appreciate it.
Hey, thanks
All right.
everybody.
Guys,
Great
have a
time.
great night.
Thanks a lot. Have a great night.
Bye.
Bye.